a functional appliance, but we have to correct the retroclination and then you can correct for better result. So now this slide is very important in terms of understanding how a constricted maxillary arch can also contribute to a skeletal class 2 malocclusion. So C for the arch form. So whenever you have a patient who has got a constricted arch, like you can see here, there is a lot of constriction in the premolar region and in the anterior region. So what happens is the mandible cannot come forward on its own. So what you need to do here, it is called as a foot and shoe effect. So you can widen the maxillary arch as a first part of treatment even before going on with a functional appliance, and then you can see the change in the position of the mandible. So once you expand the maxillary arch, either you can use a skeletal maxillary expansion device like a Hyrax screw, or you can carry out dentalveolar expansion with a jack screw or a quad helix or any other appliance. The mandible can come forward on its own. So widening the maxillary arch is also a very important part of skeletal correction for a class 2 malocclusion. Another scenario, what you can do is you can combine both. You can incorporate an expansion appliance in your functional appliance also. Both can be combined, but it's always advisable if you can notice a severe constriction in the maxillary arch, first correct that and then go for a functional appliance. So as you can see here, in this scenario, I'll just quickly take a minute to explain. Whenever you have a palatally placed lateral incisors because of crowding, in that case the mandible cannot come forward. So what you can do is, you can carry out a very brief period of fixed appliance to correct the position of the lateral incisors and then go ahead with functional appliance. So what I am trying to tell you here is that in certain clinical scenarios, directly you may not give a functional appliance. That's not a good thing to do. You can have a brief period with a fixed appliance or with an expansion appliance, and then you can go ahead with a functional appliance. As you can see here, lateral cephalogram is a very important contribution to our diagnosis and treatment planning. So there are some indicators which will tell us how much is the problem and which jaw is at fault. So here, as you can see in the lateral cephalogram, this is the cervical vertebrae which I was talking to you about. This is your C2, C3 and C4. Atlas is usually not seen. So the growth and development of this cervical vertebrae is a very good indicator for identifying the pubertal growth spurt. So the ideal stage would be CVMI 3 and 4, very ideally indicated for functional appliance. So if you want to give a headgear, you can give it in CVMI 1 or 2 stage. In 3 and 4 it's too late, and class 3 malocclusion also has to be given in the first and second stage. But for functional appliance, the third and fourth stage is very ideal. Now what happens when the child is in the 5th stage? Then there is a very less scope for the functional appliance to work. So here is a patient who's got a class 2 division 2 malocclusion with a retrognathic mandible. As you can appreciate that the upper incisors are severely retroclined and there is a severe convexity in the profile. You can observe the VTO is nicely improved just by bringing the mandible forward. You can appreciate the difference in the profile. So here again, as I told you, any class 2 division 2 patient, the mandible is forced to go back. There is a backward path of closure. So that is a very good prognostic indicator for a functional appliance. So you can appreciate that the mandible is going back as the patient opens and closes the mouth. But usual path of closure is the mandible has to come forward from centric relation. So this is an important video which will contribute to your diagnosis. And intraorally you can observe both the central incisors are severely retroclined and labial tipping of the lateral incisors with a broad square shaped arch with crowding in the lower anteriors. The most significant feature of any class 2 division 2 malocclusion is the deep bite. This deep bite is so traumatic that it can cause periodontal problem and attrition of the lower incisors, or even the lower anteriors can become non-vital. So you take the OPG, the lateral cephalogram, you can appreciate there is lot of growth in this child. You can appreciate the vertebrae are rectangular and there is about 75% of growth left. So the treatment plan for this patient would be to have a brief period of fixed appliance just to correct the retroclination of the incisors. So what you are doing here, you are converting a class 2 division 2 malocclusion to a class 2 division 1. When you convert it to a class 2 division 1, the overjet is increased and the mandible you can bring the mandible forward using a functional appliance. So this patient at the end of a brief period of fixed appliance for about 4 months, you can see now the retroclination of the incisors is completely corrected, but still the profile remains convex, and you can, in this type of cases, there is no other way other than correcting the convexity by functional appliance. In young age, if you have corrected the retroclination, there definitely is a chance for the mandible to come forward on its own. So now considering the positive VTO, and we have converted a division 2 to a division 1 malocclusion with a brief period of fixed appliance, and then also the path of closure is confirmed to see whether it's still backward, and now you give a twin block. You just debond the brackets in the premolars and remove the molar band and have a sectional fixed appliance from canine to canine, just consolidate that, and then you can give a twin block for about 6 to 8 months, then continue with the fixed appliance to complete the treatment. So here the point is, if you have retroclination, convert it to a class 2 division 1 malocclusion and then go for a functional appliance. Now moving on to headgear. This appliance is not used very commonly nowadays, but if there is a case of a maxillary prognathism, this is the best choice of appliance, wherein depending on the growth pattern, you choose the type of headgear. What it does is, it restricts the forward growth of the maxilla, and depending on the growth pattern, you can either give a cervical pull or a high pull headgear. So this is a high pull headgear. This is given in patients with vertical growth pattern, wherein the entire maxillary arch is distalized. The dentition also is distalized, wherein you can see there is a change in the inclination of the upper incisors. But nowadays making the child to wear a headgear is very challenging, but still some cooperative patients do wear this and the results are very encouraging. Now I would like to give you a brief insight of how Invisalign has come forward to correct the mandibular advancement as well. Not severe cases, you can take a very mild or a moderate cases wherein you can go ahead with their advancement appliances. Personally, I have not given any appliance to my patients, but it is an insight. You can go ahead and give this appliance also in only mild to very moderate cases. So as I told you, the choice of functional appliances, all these patients, they will benefit a lot with functional appliance. If not functional appliance, no other appliance or fixed appliance can bring about a change in their face. You can correct the dentition with fixed appliance using elastics, using extractions, using distalization, but the change in the face cannot be achieved except with functional appliance. So these are some of the cases which are very ideal and works well for functional appliances. Now I move on to class 3 malocclusion, where it's the prevalence in our place is quite less compared to class 2s, wherein either the maxilla is retrognathic or the mandible is prognathic, or it can be a combination. But most often, as in contrary to class 2s, the class 3s are a combination of maxillary and mandibular problem. The etiology can be hereditary. One point of caution: if you have a patient who gives a strong genetic history of a class 3 malocclusion, if you yourself look at the mother or father having a class 3, first caution is, don't promise any outcome. You can treat them with face mask, you can treat them with chin cup, but say whatever results are going to be achieved, just accept it. Don't give 100% confidence to them and convince them that the face will completely change to straight profile, the class 3 will completely get corrected. It may get corrected with your treatment for 6 to 8 months, but with follow-up after 1 year or 2, the patient will again end up in class 3. The growth spurt again is going to worsen the class 3, in which the patient might go in for an orthognathic surgery later. So whenever you are handling a patient with a genetic history of class 3, tell the parent you are only attempting to correct the malocclusion by growth modification using a face mask, that's a reversible headgear, or a chin cup, and definitely there may be a need for an orthognathic surgery later. Otherwise, after the treatment is over, the patient is going to come to you with a relapse or continuous growth of the mandible with a full-fledged class 3, wherein it's not going to be a comfortable situation for us and for the patient as well. So have this word of caution. And clinical features, as you can see here, it completely varies in a patient with retrognathic maxilla and in a prognathic mandible. See, this child with such a strong prognathic mandible, you cannot correct this with a chin cup. Definitely it will not work. So in these type of cases, directly, and you can imagine what the psychological trauma will be for the child. In these type of cases, we can go ahead for an orthognathic surgery at this stage and tell the parent that there may be a need for an orthognathic surgery after completion of growth. Even though we do surgery twice for the patient, for this point of time, the psychological benefit is going to be greater. So in these type of cases, you cannot correct with growth modification. It's a straightforward surgical case. And here in this child, if you can see, there is a malar deficiency. There is a malar prominence which is missing, and you can see an obtuse nasolabial angle, which all point out to a retrognathic maxilla. So the profile will be concave, there will be anterior divergence, lips may be competent, incompetent depending on the inclination of the incisors. Position of the tongue also should be noted. Sometimes in class 3 patients you might have macroglossia, which we might miss. So look for the crenations on the lateral borders of the tongue. If you have a patient with macroglossia, imagine if you are going to take the mandible back, the tongue space is going to get further reduced. So what is going to happen? Entire relapse will be there. The tongue cannot hold back. It will come forward. So you are going to end up with relapse. So look for the tongue in patients with class 3 malocclusion where they can be anteriorly placed or there can be a macroglossia. In that case, you should look for alternate positions without altering the position of mandible by bringing the maxilla forward, which can increase the room space for the tongue. So 11-year-old girl, this patient had a strong genetic history, and what we have done is a VTO, wherein in class 2 I said you bring the mandible forward. But in class 3, you are supposed to keep a cotton under the upper vestibule and look for the fullness of the upper lip. If that is favorable, then it means the patient has a maxillary retrognathism. Otherwise, the profile will not improve if it is a mandibular prognathism. So this is how we do a VTO in a class 3 patient. We've just kept some cotton under the upper vestibule. As you can see here, there is an anterior crossbite and a reverse overjet at molar towards class 3 relationship, canine and class 3. And one more important point what I want to highlight is the asymmetry in class 3. Okay, in class 2 patients, the asymmetry is not that common. But in class 3, a facial asymmetry is a very common feature which is not to be neglected. Because whenever you have a constricted maxillary arch, the mandible accommodates itself by shifting to one side. It either goes to the right or to the left so that the patient will have good occlusion at least on one side. So as the patient starts to shift the mandible in the childhood, later it becomes a skeletal asymmetry. So this skeletal asymmetry cannot be corrected with any growth modification appliance, and there will be asymmetry of the chin and the entire mandible will be deviated to one side. To some extent you can improve it by expanding the maxillary arch, otherwise you will have to correct it only by doing an orthognathic surgery. So the point here is asymmetry of the mandible is more common with class 3 malocclusions, and you are supposed to elicit the asymmetry present and understand whether the asymmetry is skeletal or is it functional. So we take the X-ray with lead points to know more about the maxillary prognathism in class 3 patients, and this is one cephalogram which has to be taken in class 3 patients with facial asymmetry. This X-ray is called a PA cephalogram or a postero-anterior cephalogram, which will help us to identify the extent of the asymmetry. So one more X-ray. Without this, it's very difficult to identify from where the asymmetry starts. Is it only in the mandible or it starts from the midface? This X-ray will give us all the information. So in most of the class 3 patients, this X-ray is very much required. So as you can see here, class 3 or growth modification is very challenging unless it's mild or moderate. And you must also remember, when you don't correct the anterior crossbite in the initial stage, it can lead to wear of the lower incisors, and there can be tipping of the lower incisors, retroclination and washboard appearance in the lower incisor region. Okay, you will not know. Suddenly one day you will see recession, you will see lot of gingival inflammation in the lower anteriors. What has happened? You must be wondering whether what really happened. You won't have a clue. The point here is the labial cortical plate in class 3 patients is very thin. So as a dental compensation, when there is retroclination of the incisors which occurs, the roots are prominent and you can see that's called as a washboard appearance. The point here is already the incisors are retroclined, so you are not supposed to camouflage that malocclusion by further retroclining them. You will develop fenestration, dehiscence. How much ever bone graft you do, nothing will take up. So look for the lower incisors, the cortical plate and the thickness of the bone, especially in the lower anterior region. So what happens, you can treat with face mask or chin cup, but then the case has to be selected very appropriately. So here is a flow chart which talks to you about class 3 management. As you can see here, if it's a growing child and it's a skeletal component, you can go for a functional appliance or an orthopedic appliance. But usually as a routine practice, we don't give class 3 patients with functional appliance. The better results are achieved with a reversible headgear or a face mask therapy. Chin cup gives a very limited result, so it's not being used that common unless just to correct a very mild mandibular prognathism. Why I put this slide is that class 3s is very difficult to treat. Okay, it's easy to diagnose but very difficult to treat. Successful treatment is possible in mild cases. In other ways, if the child comes at the end of the pubertal growth spurt, there is no point even trying the growth modification procedure. You can either go for camouflaging the skeletal malocclusion or wait for the growth to complete and then go in for an orthognathic surgery. That's the best thing to do. So as I told you, I will run through the functional appliances. You can give a Frankel 3 appliance, it works the best, but making the patient to wear this appliance is extremely challenging. You can use a chin cup for cases only with mandibular prognathism, which means the maxilla should be normal. This is a very commonly used appliance for a class 3 patient. It's called as a reversible headgear, wherein it protracts the maxilla and the maxillary dentition, and it restricts the downward, produces downward and backward growth of the mandible. So it cannot reduce the growth of the mandible, it only controls the mandible from coming forward. So here is again one more so here I just put a video which will explain you how a face mask really works and corrects class 3. I'm not able to play that, I'm sorry. I'll show that with a case. So here is a patient who's got a class 3 malocclusion. Remember, the ideal age to treat a class 3 is at the time of eruption of the maxillary incisors, say 7 to 8 years of age. But later than that, if you're going to treat the patient, be cautious that you will get whatever change possible is only with dentoalveolar correction. That is, you can only move the teeth. The jaw correction will be very minimal or nothing at all. So this girl came to us a little late, but we still attempted with the face mask therapy because it's not a very severe class 3. As you can see here in this case also, there is an asymmetry in the mandibular position. So what we do here, we give a hyrax which will open up the circummaxillary sutures. 2 points you need to understand here. If you have a posterior crossbite, then you activate the hyrax appliance to correct the posterior crossbite till you see a midline diastema in the center and you have achieved a scissor bite in the posterior teeth. That's the overcorrection what you have to do. If your posterior occlusion is fine, there is no posterior crossbite, then what you do is you only activate it for 10 days for the circummaxillary sutures to open. You don't need to achieve the maxillary expansion in these type of cases. So the difference is in the time of activation and the number of days how you activate the appliance. So this has to be done first so that the circummaxillary sutures loosen up, and then you go ahead giving a face mask to the child. This is called as a petit type of face mask, which is the most commonly used one and a comfortable one for the patient. So as you can see here, there are some elastics which runs from this hook which you have placed intraorally, that brings the maxilla forward and also the maxillary dentition. So this goes for a period of about 6 to 8 months, and as you can see here, the anchorage is taken from the forehead and from the chin. Once the first phase of treatment is over, you go ahead with the fixed appliance to align the teeth. This is how we end up with the post-treatment with a straight profile. You can see there is a good correction of class 3. Though we started the case late, in terms of growth, we could achieve good result, it's because of the minimal class 3 malocclusion. This would have not been possible if the case was a severe one. So class 1 molar, class 1 canine with a good overjet and overbite with coincident midlines can be achieved. So that brings to the end of my presentation. I would like to thank Vignesh sir and Sridevi ma'am with all the learning what we have achieved, what I have achieved in Ramchandra for the past 15 years is immense, and I would like to thank my postgraduates and all the faculties also here for the clinical support and encouragement. Thank you all. I think Rashik, I finished 5 minutes before. So any questions?